You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
Rock and roll.
Yeah, so this is so I want to express my appreciation to you, Chris, and you know, it's really a pleasure to be associated with the COLA conferences again this year. This is such a successful program, and it's really provides an important resource for our specialty, not only fellows in training, but for all of us in the specialty of allergy and immunology. So congratulations on your success. And again, I'm pleased to contribute this year by discussing urticaria and angioedema. And I guess let me start scratching below the surface with a picture of the Rock and Roll Hall of Fame, which is in Cleveland, Ohio. And if you're in our vicinity in Northeast Ohio, this is clearly worth a visit for you to, you know, carve out some time in your trip here to visit the Rock Hall. While you glimpse my disclaimer slide, again, I want to express my appreciation to you, Chris, for the opportunity to be with you this morning. And I have three learning objectives that you will, in an hour or less, be able to describe an evidence-based and cost-effective approach to diagnosis and management of patients with chronic urticaria, recognize patients with physical urticaria angioedema syndromes, or what are now called chronic inducible urticaria syndromes, and identify patients with refractory chronic urticaria angioedema. So urticaria angioedema, as we all know, occurs in all age groups, more common in women age 35 to 60. Chronic idiopathic urticaria angioedema, now called chronic spontaneous urticaria in a number of sources. Management of this condition entails realistic expectations and regular use of pharmacotherapy. The realistic expectation part entails the implication that without regular use of pharmacotherapy, patients will have worse outcomes, and that what I usually tell patients, whether you think you need it or not, you need to take your medicines every day. This is a frequently frustrating or vexing condition, if you will, for both clinician and patient. Less so in the last few years based on enhanced understanding of the condition and better medications with which to treat it, particularly the patients who are antihistamine resistant. We'll talk about that. So I'm going to be presenting information in a case-based fashion. So let me introduce you to DC. Patient I saw a number of years ago, 53-year-old school teacher with a 10-week history of daily episodes of pruritus and hives. She described erythematous wheals ranging from pencil eraser to nickel in size with the duration of less than 24 hours, no residual bruising. And I would add that at initial visit, patients may have no lesions, so physical exam may be completely unremarkable, but particularly in recent years with advances in technology, I don't know whether you can see me or not, but I'm showing you my cell phone. Patients frequently will, even if they don't have lesions, will show you pictures that they have stored on their cell phones in anticipation of the visit. And these are helpful, or can be helpful. So DC experienced an episode of facial swelling, but denied episodes of throat constriction. She denied a history compatible with physical urticaria syndrome. She was high-free while taking an oral steroid burst taper, but then relapsed when this had been completed. And 1 month prior to the initial visit, an oral contraceptive was suspended without improvement. And she was taking an over-the-counter antihistamine on an as-needed basis, which I would add is it was a first-generation antihistamine. So this condition, as summarized in these two papers in 2006 and more recently in 2014 by Dave Weldon, this is associated or can be frequently associated with a huge hit in terms of quality of life. Health-related quality of life, as you're aware, is a measure of an individual's perception of the impact of an illness or its treatment on their life in terms of physical, emotional well-being, satisfaction with social functioning. And this is a patient-reported outcome metric. It's assessed by the individual patient, not by the provider. And multiple guidelines have encouraged the use of PROMs, or patient-reported outcome measures, at initial visit and subsequent visits to track the course of the impairment in quality of life, and in many cases, fortunately, the improvement in quality of life with therapeutic interventions that we prescribe. And there are a number of agents that are validated in the current issue of the Journal of Allergy and Clinical Immunology in Practice. One of them, the UAS7, was validated in a study, as I recall, from Montreal in children. So this has been these measures have been well validated in adults and a number of them in children. An underestimated burden that I want to point out in patients with chronic urticaria, and also in patients parenthetically with atopic dermatitis, which is not the focus this morning, as you know, is impairment in sleep. In recent years, as these reports have appeared in the literature, I've frequently asked, and now routinely ask, patients to tell me about their quality of sleep when they come in with chronic urticaria. There is an association of insomnia with disease activity, as shown here: problems falling or maintaining sleep, problems waking up too early, interference with daily functioning. This is a huge issue, and patients, understandably, with a higher pruritus score, were less satisfied with their sleep pattern. So, in response to this question, what's the worst aspect of your urticaria? Swellings. The swellings. Itching is number two, and then a number of items are anywhere from, if you look up here, there are a number of other items. I want to point out the unpredictability of attacks. This is an issue certainly with chronic spontaneous urticaria, where these are seemingly random. Feeling embarrassed is a major issue. I suspect that's one of the reasons that the swellings is rates number one. The swellings frequently, as you know, may affect the hands, the face. There's a social stigma associated with this. So when patients come to see us, they've taken a big hit in terms of their quality of life. The best evidence-based management recommendation for DC is, Chris, I'm hoping you're in a room with your fellows and that you can encourage your fellows to collaborate and provide what the consensus as to the best answer here.
Yeah, we're all online, so it's be individual. Yeah.
Okay, well, let me just go through it then. That's fine. Previously, you've been in a conference room, but I understand that we're moving, and in our program too, we're moving more to Microsoft Teams. Excuse me, my printer makes noise when it's not supposed to. Okay, the best evidence-based management recommendation for DC is A, prescribe avoidance of food additives, which are likely to be associated with resolution of urticaria angioedema. B, perform immediate hypersensitivity skin testing to foods and inhalants. C, obtain extensive laboratory testing, including ANA C1 inhibitor level and functional assay. Or D, tell DC she has a condition that is likely idiopathic. And the best answer is D. So the universe of chronic urticaria is categorized as acute or chronic. Acute is less than 6 weeks. Chronic is 6 weeks or more. And in acute urticaria, not infrequently, we are able to identify a cause. For instance, a viral illness, a drug. Chronic urticaria, the overwhelming majority of patients, we do not identify a cause. This is an often cited and classic, if you will, paper from 1969. I still like the 60s. Paper by Champion and colleagues, 554 patients with chronic urticaria angioedema. And as you can see, About 2/3 of cases have both urticaria and angioedema, with the remaining third split, almost evenly between one or the other alone. And in this study, what they reported was that the etiology was unknown in 79%. Now you see this estimate in a lot of review articles about chronic urticaria. 80% of cases are idiopathic, and I believe this is the original source for that estimate. But if you dive into what was going on with the 21% in whom a cause was established, many of them had physical urticaria syndromes, which we now categorize as chronic inducible urticaria. I don't believe that we would accept this as an answer to a patient in terms of a cause per se, certainly not an exogenous cause. And you'll see that 3% of patients had what the authors called allergic urticaria. These were patients who had urticaria that was attributed to a variety of foods, not well substantiated. And there were several patients who had chronic urticaria attributed to they were penicillin allergic by skin testing and history, and they had their urticaria was attributed to consuming food items such as dairy products in which it was hypothesized trace amounts of penicillin were present. I don't even know that that's possible, but let's assume that it is for the moment. So basically what we see here is that in less than 5% of cases, an etiology was established. And I suspect and there are other data supporting this, that this is actually an overestimate. First time we see the patient, it's important to obtain a detailed history, inquire about the urticarial lesions. Is it a pruritic sensation or a burning or painful dysesthesia? The latter possibly a clue as to the presence of urticarial vasculitis, as would be, for instance, residual bruising beyond 24 hours. So it's important to inquire about that and the typical duration of lesions. What are the provoking factors for these lesions, which are important clues as to the possible presence of an inducible urticaria syndrome, and associated fever, arthralgias, recent travel, which may be clues in terms of an underlying etiology in terms of an infection. I'm going to spend a bit of time talking about guidelines. I'm not sure where else in the COLA series you're going to get this information, but it's certainly important with regards to interpreting guidelines, including the recent EPR4 guidelines 2 years ago released for the evaluation and management of asthma. Evidence-based medicine is the integration of 3 elements as shown here: best evidence, clinical expertise, patient values and expectations, or patient values and preferences. So as shown in the center here of this triad, this is the confluence of these 3 factors. So evidence-based medicine is not an intervention that does not include clinical judgment or clinical expertise. And with regards to patient values and expectations, there is a trend, as shown here, over the last 30 years of a transition from what is called, in retrospect, in the era 30 years ago plus, of opinion-based medicine, in which there's a reliance on memory, emphasizing clinical judgment and clinical experience, to physician-centered evidence-based medicine. Practitioner experience is still important, and this acknowledges patient values, but and you can see this trend in the evolution of guidelines as well, that guidelines have become much more evidence-based than previously in an era of consensus-based guidelines. We have now transitioned to patient-centered evidence-based medicine, and this is reflected in the EPR4 guidelines. One of the reasons I mentioned these, clearly there was an effort to involve patient values and expectations in terms of creating and issuing these guidelines. There were focus groups with patients who had asthma, and there was asthma outcomes were rated hierarchically in association with these interviews and focus groups. So in patient-centered evidence-based medicine, it entails an effort to integrate physician experience with patient values and to focus on outcomes that are important to patients. So as long as I've talked about asthma, I'll use that as an example, but there are a number of examples here within our specialty and elsewhere in clinical medicine where you can see that there are a number of surrogate outcomes that previously were the focus of papers that you'll see in the literature, where an asthma intervention, say, was evaluated in a randomized controlled trial and the primary outcome was FEV1. Well, this is not a patient-centered outcome, although clearly when lung function improves, patients feel better. But a more patient-centered outcome for asthma would be, for instance, asthma control or the rate of asthma exacerbations over time. So how are the concepts of evidence-based medicine used to develop guidelines? So in the GRADE approach, which is now used increasingly in our guidelines, the GRADE approach being accepted by most specialty societies now, we begin by formulating a question, and a question typically uses an approach that is abbreviated PICO, P-I-C-O. So using an example for a biologic agent that is currently under study, let's say we have a new biologic agent, topgunizumab, for chronic refractory urticaria. How would we go about evaluating from the standpoint of a guideline recommendation the biologic agent topgunizumab? So we would develop a PICO question. The question, is topgunizumab effective for, I should say chronic urticaria, my apologies. Chronic urticaria is too vague. What is the efficacy of topgunizumab for refractory chronic urticaria is better? And better yet would be in patients 12 years and older with severe chronic urticaria refractory to high dose medication. What is the effectiveness of add-on topgunizumab compared with placebo for achieving control? All right, so I use this example for a recent talk on asthma. My apologies, but here we are. Topgunizumab for chronic refractory urticaria. It's the same concept. Patient or population is P. Intervention is I. Comparator is C. Outcome is O. So we would have here severe asthma, where it would be severe urticaria. Actually, it would probably be antihistamine-resistant urticaria. The intervention would be topgunizumab. The comparator would be placebo, and we would look at an outcome, which would be the exacerbations over time for urticaria, or would be the rate of control over time for chronic urticaria using one of the instruments that I showed previously. So what we would do is we would use these terms to do a literature search. And then we would assess, we would use these terms for a number of search engines and identify a number of articles in the literature, then critically appraise those articles. We would want to see randomized controlled trials. If you look off at the right, the randomized controlled trials begin at a high level of quality. And then we would downgrade these studies based on a number of methodologic issues shown here in the far right. Alternatively, depending on the search, we may not have many randomized controlled trials, so we would look at observational studies. And there are methodologic criteria, and there are 3 listed here. And I'm going to go over this a little more and later on in terms of some of the criteria here that can be used to upgrade the quality of an observational study, which in contrast to a randomized controlled trial begins at a low level of quality of evidence. So then evidence tables would be generated, and these would be presented to our guidelines panel, and the guidelines panel would move from consideration of this evidence to a recommendation. Now, there can be a separation between the level of evidence and the level of the recommendation. So, for instance, if we were doing an anaphylaxis, I'm jumping around here from urticaria to asthma, now to anaphylaxis, but it's the best example I could think of, and it's readily appreciated. If we were doing an anaphylaxis grade parameter, and we were evaluating the therapy of acute anaphylaxis, we would want to issue a strong recommendation for the use of intramuscular epinephrine. However, the level of evidence supporting this is low. There are no randomized controlled trials, nor will there ever be, to support the therapeutic utility of epinephrine. So although the evidence is not high quality, nonetheless, we issue a strong recommendation. And when moving from the quality of evidence to the recommendation, whether this is a strong recommendation or a conditional recommendation, we evaluate not only the quality or certainty of evidence, but also the balance between the potential for benefit compared with the potential for harm or burden, resources and cost, and patient values and preferences. So we're back to DC, and we're going to think about what kind of testing to do. What kind of diagnostic testing do you do in a patient who comes to see you with chronic spontaneous urticaria? Well, we looked at that here at the Cleveland Clinic, and we asked this question: what proportion of laboratory tests obtained in patients with chronic urticaria angioedema lead to a change in management and in outcomes of care? This was published more than a decade ago in the Annals of Allergy, Asthma, and Allergy. This is a retrospective analysis of a random sample of adult patients with chronic urticaria. From 2001 to 2009, 356 cases were identified that fulfilled our inclusion criteria, which were, according to ICD-9 criteria, a diagnosis of chronic urticaria, and they had their labs ordered here at the Cleveland Clinic. 1,872 laboratory tests were ordered for these 356 cases. 319 tests, or 17%, were abnormal. So roughly 1 in 6 tests was abnormal. 30 patients, 8.4%, underwent additional testing based on the results of the additional test results that came back. A mean of 6 tests were obtained for each patient. As shown here, abnormalities were commonly seen in complete blood counts, roughly a third, and in complete metabolic panels, almost 10%. The majority of abnormal CBCs had a slightly elevated or reduced neutrophil count. Excuse me. And or a slightly elevated eosinophil count, for which no further workup was pursued. Most abnormal complete metabolic panels involve slightly abnormal transaminase levels, for which further workup was not pursued. SED rates elevated in about 1 in 6 cases in which this test was ordered. So, excuse me, my apologies. I should have said this previously. I'm just getting over COVID. So, although I'm COVID negative now, this was about 5-6 days ago. So the question is, in how many patients was a test abnormal that then led to a change in management resulting in improved outcomes of care? And the answer is 1 patient. She had a history of hypothyroidism and improved with an increase in the dose of levothyroxine from 88 micrograms to 150 milligrams a day. Previously, her chronic urticaria was well controlled on 175 micrograms of levothyroxine, but A few months prior to her evaluation, she had an MI and her levothyroxine dose was reduced. Her urticaria worsened and persisted despite regular antihistamines, and she had elevated levels of antithyroid antibodies. After titration of her levothyroxine, her urticaria resolved and she was able to taper off antihistamines. Excuse me. So our findings support recent recommendations to limit laboratory evaluation in patients with chronic urticaria angioedema, so the diagnostic evaluation can serve to rule out an underlying cause in a cost-effective manner, while in most cases providing what I would call a reassuring value. And there are other reports, as shown here, that have also supported the assertion that routine laboratory screening is not cost-effective. This was shown in a paper by first author Mark Shaker that appeared in the Journal of Allergy and Clinical Immunology 2 years ago. ICER, as you may be aware, stands for Incremental Cost Effectiveness Ratio. It's a metric reflecting the economic value of an intervention, and these are very high because the benefit associated with these tests is extraordinarily low. And this is another paper from, as I recall, Mayo Clinic, Jacksonville, Journal of Allergy and Clinical Immunology in Practice in 2019, 725 patients, 75% of whom had one or more laboratory tests performed. More than 90% were within normal limits, and changes in management leading to improved outcomes were rarely uncovered. So don't do extensive laboratory testing in patients such as DC. This is from our urticaria parameter from 2014. We acknowledged in the parameter there's an honest difference of opinion concerning appropriate tests that should routinely be obtained in a patient such as DC. A majority of members in the practice parameters task force, this is a consensus-based recommendation to do these laboratory tests, CBC with diff, sed rate, liver enzymes, thyroid stimulating hormone, but we state in the parameter that the utility of performing these tests routinely has not been established. So the caption here reads, "We don't know for sure until we run more tests, but it seems you picked up something while you're in Africa." So clearly, if you uncover in the history or a comprehensive physical exam some information or findings that would imply that there may indeed be a cause, there's no question that targeted laboratory testing is appropriate. However, for those individuals who have an unremarkable history in physical exam, extensive laboratory testing is not going to be cost effective. And this is one of the recommendations in the Choosing Wisely program. Don't routinely do diagnostic testing in patients with chronic urticaria, because in the overwhelming majority, a definite etiology is not identified, and these abnormal laboratory tests that tend to come back are not going to lead to improved outcomes. So with DC, indeed, we did a CBC with differential complete metabolic panel, TSH, and sed rate, and the findings were within normal limits. So I have a couple slides on histopathology. The pathogenesis, this is a so-called round cell or lymphomononuclear infiltrate, a perivascular infiltrate surrounding small venules, prominence of CD4 positive lymphocytes, monocytes, virtually no B cells, granulocytes may be present. In this setting, cellular recruitment occurs via release of pro-inflammatory and inflammatory factors. And that once this is set up, in other words, once these signals have gone on in the immune system for these cells to infiltrate into the skin, this infiltrate continues to be there and be perpetuated and rev up inflammation and release histamine and other mediators. And histopathology of a typical urticaria lesion is shown here. Again, a lymphomononuclear infiltrate. We do not see findings seen in other cutaneous conditions, including vasculitis, cutaneous mastocytosis, etc. Step care management is shown here as published in the most recent practice parameter. I'm going to go through each of these steps. High quality evidence supports the therapeutic utility of H1 antihistamines going back 70 years. First generation agents, as you all know, are associated with sedative and anticholinergic effects. So we in our guidelines and the recently released international guidelines and guidelines from South America, other countries in Europe, Asia, all of these guidelines agree with the first step of therapy, which is a second-generation antihistamine agent, which these agents being efficacious and are, in most patients, better tolerated than first-generation antihistamines. So monotherapy with a second-generation antihistamine is what's recommended at step 1, in addition to avoidance of triggers and relevant physical factors if chronic inducible urticaria is present. So when, let me just say, when, excuse me, H2 antihistamines were critically appraised. The evidence turns out to be difficult to interpret because there are small numbers of patients studied. Different H1 antihistamines were used. Many studies use cimetidine, which is not the H2 antihistamine that we typically recommend because of the drug-drug interactions. Superior efficacy was shown in some studies in which hydroxyzine was combined with cimetidine. However, it turns out there's a drug-drug interaction between hydroxyzine and cimetidine, such that the metabolism of hydroxyzine is slowed. So when you take hydroxyzine with cimetidine, the blood level of hydroxyzine, or the effective dose, if you will, is increased. So in the studies in which there's superior efficacy of hydroxyzine and cimetidine compared with hydroxyzine and placebo, is that due to an effect of cimetidine or an H2 antihistamine, or is that due to the fact that there's a drug-drug interaction? So there are a lot of question marks about this, and this is what is categorized as weak evidence, so that there is a conditional recommendation for the use of H2 antihistamines because the clinical experience is that some patients do benefit, and it's a well-tolerated medication that is not expensive. And similar story with anti-leukotrienes. There are most randomized controlled trials show efficacy, some don't. Data suggest a salutary effect may be more likely in individuals who have exacerbation related to taking aspirin or non-steroidals in certain physical urticaria syndromes, such as delayed pressure urticaria angioedema, or in some reports, patients with an autologous serum skin test. We'll get back to that a little later. So what we typically recommend in those individuals who do not respond to monotherapy with a second-generation antihistamine, in addition to the possibility of treating with H2 antihistamine with or without anti-leukotriene, is dose advancement of second-generation antihistamines. More than a decade ago, this was shown in this study from, I think we're in Bulgaria now. 80 patients with refractory urticaria, 72% previously treated with steroids, were randomized to one of two antihistamines with dose advancement to 4 times the standard dose. You can see here that individuals are randomized to either levocetirizine or desloratadine at a dose of 5 milligrams, which is the FDA-approved dose. And then at these return visits serially, which were done weekly, if you look on the top, you'll see that subjects followed up weekly, and if they were well controlled, they exited. But if they were not well controlled, they went up to the next level of antihistamine use. And then at week 4 or visit 4, if they were not well controlled, they crossed over to the other antihistamine. And what these investigators found was that approximately 75% of their subjects were responders to higher than conventional doses. And with the crossover, nobody improved with a switch to desloratadine, but in those individuals who were randomized to desloratadine initially and then were switched over to levocetirizine, a number of them did improve. So with regards to step 2 then, there is evidence supporting dose advancement of second-generation antihistamine. Another possibility, which I did not mention, entails adding another or a different second-generation antihistamine. This is not endorsed in the European or international guidelines, including their most recent iteration, but is recommended, as you can see in the practice parameter, most recent practice parameter. And again, the H2 antagonist, leukotriene receptor antagonist, is based on weak evidence. We do have a recommendation to add a first-generation antihistamine to be taken at bedtime. And the recommendations concerning that are mixed. I would add that in the most recent international guidelines, they are, with regard to the leukotriene receptor antagonists, they are at equipoise. In other words, it's, that from their judgment, the desirable or undesirable effects of that intervention are equally balanced, so they don't recommend it. So what happens when you've advanced a patient as tolerated to 4 times the dose of the FDA-approved dose of the second generation antihistamine, and they're still not well controlled? This is clipped from the international guidelines, and which state that if symptoms persist, that it's time to prescribe either omalizumab or cyclosporin. They also put montelukast here, but again, the recommendation is plus minus. So what happened with DC? She was placed on fexofenadine in the morning, cetirizine at night at FDA-approved doses, ranitidine 150 milligrams twice a day. She was still not well controlled, so montelukast was prescribed. Still not well controlled, so we cautiously advanced her cetirizine to 30 milligrams at bedtime, and then she was well controlled. The European guidelines recommend complete symptom control. In other words, no urticaria symptoms. When I manage patients, I usually offer them the opportunity to participate in the medical decision-making process and inquire as to whether the minor episodes that they may still be experiencing are sufficiently bothersome that they would wish to have more medication added. Some patients elect to tolerate, some minor breakthrough episodes that don't impact on or don't interfere with desired activities rather than dose advancement. But what if DC was not well controlled and she continued to have flare-ups? In the practice parameter, we recommend dose advancement with a potent H1 antihistamine such as hydroxyzine or doxepin. Doxepin is the most potent antihistamine that we can prescribe. On a molar basis, it's 775 times more potent than diphenhydramine. This is a paper published in 1985 from the Mayo Clinic. It's a double-blind crossover study, 50 patients with chronic idiopathic urticaria. And what you can see here is on the doxepin arm of the study, there was a statistically significant and clearly clinically significant difference, such that in the doxepin arm, these patients were more likely to be controlled and more likely to have pruritus and, clearing of pruritus and their urticaria lesions. I would add that on the doxepin arm, there was statistically significant lower rate of sedation compared with diphenhydramine. This is another double-blind placebo-controlled crossover study that was carried out in the 80s. Just like I like the 60s, I also like the 80s. Dramatic reduction in urticaria lesions and degree of itch discomfort, as you can see here, 75% decrease in angioedema, and a huge reduction in the PRN use of antihistamine tablets in the study. So clearly, the evidence supports the efficacy of doxepin. The issue is, however, that a large number of individuals are prone to experience drowsiness. In some cases, this resolves with regular use. In other patients, it persists. Anticholinergic effects are prominent, and subjects can gain weight. But most people who go on this and can tolerate it will, in my experience, tell you it can be helpful. However, since this recommendation was made in the practice parameter, a number of studies have shown that there is a risk for cognitive impairment. A risk for acute cognitive impairment related to anticholinergic drugs was previously recognized, particularly in older individuals. But more recent evidence has indicated that even when you suspend the drug, this effect may be irreversible. So here's a paper that was published in 2015, a prospective population-based cohort study in Seattle. More than 3,000 subjects, 65 and older, who enrolled with no dementia at baseline. There were two periods of initial recruitment in the mid-90s and early 2000s. I'll get back to that. Subjects were followed up every 2 years, most recently in 2012. The paper was published in 2015. A computerized pharmacy database was used to determine cumulative anticholinergic drug exposure and the anticholinergic drugs dispensed over 10 years. They determined rates of incident dementia and Alzheimer's, the most common anticholinergic classes, tricyclic antidepressants such as doxepin, and first-generation antihistamines such as hydroxyzine. And here are the data from the study. And what you see here is that there is indeed a dose-dependent effect. You can see this is one of the, so there are a number of criteria. I alluded to this earlier in terms of upgrading an observational study. Number one, it's a clinically significant effect. And if you look at an adjusted odds ratio, if you're 65 years old and your risk of getting dementia is increased 54% or 63%, that's a clinically significant effect. And you can see that if you look at the dose on the far right for dementia or for Alzheimer's disease, you can see that the higher the dose over time, the higher the exposure to the anticholinergic drug effect, the more likely it is, based on the hazard ratio, that you're going to develop either dementia or Alzheimer's disease. So the dose gradient is another factor. And this is a quote from the discussion section of this paper. Our findings suggest that a person taking an anticholinergic drug such as doxepin, 10 milligrams a day for more than 3 years, would have a greater risk of dementia. Every study has strengths and limitations. Study has a number of strengths in terms of internal validity. Clinical diagnosis of dementia was derived from a consensus panel of experts as the dependent cognitive variable of interest. They minimized recall bias by using pharmacy claims data. There was a dose gradient, I've mentioned that, and the risk was similar in comparing the subjects who entered the study in the mid-90s compared with the early 2000s. I pointed that out earlier and said I'd get back to it. So here it is. The notion is that even in the subjects who had remote exposure, there was a risk subsequently with follow-up in this study. And the limitations, it's not a randomized trial, but you're not going to get a randomized trial. This is not the kind of potential risk that's going to lend itself to that. In the field of epidemiology, what you look for are other reports that have found the same risk. And here we see a more recent report from the British Medical Journal. A robust association between some classes of anticholinergic drugs and future dementia incidence was observed. However, I will add, this continues to be controversial in that it's a paper from the Journal of Clinical Psychiatry, which doesn't land on my doorstep here, but I've strived to keep track of this literature because this is an important issue as to whether and to what extent we modify this recommendation for dose advancement of doxepin or hydroxyzine and a future parameter. There is an issue of what is called protopathic bias. Of the thousands of types of bias, this is the one that has a name. And it's a type of reverse causality. In other words, if somebody's starting to have dementia and they start to be a bit depressed and they have a mood change, they may get a tricyclic antidepressant to treat depression. And then subsequently, they develop dementia. So you could misinterpret a possible causal association when actually this is something that fits into the category of reverse causation bias. In other words, you're prescribing the medication for the condition that's already present, but it's early in the course of that condition. Anyways, this gets more complicated, but hopefully with further studies, this will come in clearer focus. But right now, we don't have a stronger recommendation for step 3. So after step 2, it may be appropriate, certainly when I think it's important to discuss these risks with patients when you're considering a prescription for doxepin or hydroxyzine. So patients who graduate from step 2 are candidates for alternative agents, which is defined as any therapeutic agent other than antihistamine or corticosteroid that can be used to treat refractory urticaria. And this is a list, not a complete list, of such agents. These were categorized or have been categorized by Dave Kahn in this excellent review article as either anti-inflammatory agents, immunosuppressants, or immunomodulators. And there are only 5 agents that have been studied in randomized controlled trials, and these agents are shown here. The other agents generally were studied in case series or case reports, which clearly are subject to bias and don't provide high quality evidence. Cyclosporin was studied in 3 randomized controlled trials. You can see here, based on this forest plot, combining data from two of these randomized trials. Cyclosporin was more than 3.5 times likely to be associated with benefit and symptom scores compared with patients randomized to placebo. However, there were methodologic shortcomings recognized in these studies. Adverse events were observed frequently, and it's unclear whether the potential for desirable effects significantly outweighs the risk for undesirable effects. So in the context of study limitations and potential harms and costs, the quality of evidence was rated as low, and we issued a weak recommendation or a conditional recommendation for prescribing cyclosporin for antihistamine-resistant urticaria, which doesn't mean that you shouldn't prescribe it, but what it does mean is that the potential for a benefit compared with the potential for harm and the burden should be carefully considered and discussed with the patient, and allow patients to express their values and preferences and participate in the medical decision-making process. Evidence favors prescribing omalizumab anti-IgE therapy for patients with antihistamine-resistant urticaria. This is a randomized controlled trial published in the New England Journal of Medicine almost a decade ago. 12-week study, omalizumab at doses of 150 milligrams, 300 milligrams every 4 weeks, significantly improved outcomes. These are the 2 FDA-approved doses, as you know. That is FDA approved for the treatment of antihistamine-resistant urticaria, 150 or 300 every 4 weeks. These are data from a phase 3 multi-center double-blind randomized trial, 24-week study of patients who remain symptomatic despite regular use of antihistamines, including up to 4 times the FDA-approved doses, with or without H2 antihistamine antileukotriene. So this is those who graduate from step 2 and are not well controlled. And subjects in this study, importantly, maintained their pre-randomization therapy and were randomly assigned in a 3-to-1 ratio to receive either omalizumab 300 milligrams every 4 weeks or placebo. This was primarily a safety study, but you can see that omalizumab was associated with statistically significant benefit, which was prompt. These are means here, mean change from baseline in weekly itch severity scores. And you can see that after 24 weeks, when omalizumab is suspended, over time, patients gradually return to square one. This is from a review that I published with Jim Fernandez and Tony Fernandez here in allergy, immunology, and dermatology at the Cleveland Clinic and Immunology Allergy Clinics in 2016. And looking at the UAS 7 less than 6 or the UAS of 0, which is hive-free, the number needed to treat calculated for UAS 7 less than 6 was 2.4, and the number needed to treat for being hive-free was 3.3. So those are very impressive NNT statistics, implying that omalizumab is highly efficacious. This is a review of 7 randomized double-blind placebo-controlled trials in terms of bias. These green dots, these are the types of bias that would allow us to downgrade a randomized controlled trial to which I referred previously. You don't commonly see this, where all the circles are green in each of these squares. So omalizumab is highly efficacious, and this is high quality evidence. So in the parameter, clearly we stated that the therapeutic utility of omalizumab is supported by findings by a methodologically sound randomized controlled trials. There's a relatively low rate of clinically significant adverse events, and that omalizumab is clearly indicated as a therapeutic trial for individuals with antihistamine-resistant urticaria. And when omalizumab lacks efficacy or omalizumab cannot be prescribed, best evidence favors prescribing cyclosporin. And these are data from Tom Casale demonstrating that. I'm not sure why the typing isn't visible here, but I show this to indicate that in this study of patients receiving omalizumab over 24 weeks, if you look at the dark gray and the light gray, the UAS7 score less than 6, UAS7 score of 0, again, the light gray reflecting those individuals who are hive-free, you can see that some improve promptly in week 1, week 2, early on, and we know this from our clinical experience, but that benefit continues to accrue up to 6 months. But if somebody hasn't benefited in 6 months, generally one needs to consider suspending omalizumab and prescribing alternative therapy. The other issue I wanted to discuss was how do we manage patients who improve on omalizumab? In contrast to asthma, omalizumab was approved by the FDA in June 2003. We still have patients here, I still have patients who've been getting omalizumab for 19 years. But in contrast to asthma, which is lifelong, urticaria may not be. So in patients who have improved, these authors address this issue in 132 with chronic urticaria treated with omalizumab, 300 milligrams every 4 weeks, by implementing a protocol such that after 6 doses, treatment intervals were widened by 1 week in those with well-controlled disease, and treatment was stopped subsequently at a dose of omalizumab every 8 weeks if they were well controlled. As you can see in this bar graph, 8% had a poor response such that omalizumab was suspended. 44%, omalizumab was well controlled and they continued treatment every 4 weeks. But in 29%, they were able to taper off omalizumab with a gradual taper once they reached 8 weeks. And in 20%, they discontinued omalizumab, but then they had symptom relapse such that a restart of omalizumab was required. And I think that this matches the clinical experience. What I've done is I've gone from every 4 weeks to every 6 weeks 2 times, then every 8 weeks 2 times. And if they're still well controlled, generally it's when they're hive-free. If they're hive-free and they've had their second dose 8 weeks, then they suspend omalizumab. And the experience is that some of these people are able to get off omalizumab, and others a restart is required in order to restore control. And sometimes people get stuck at the 6-week step and they can't progress beyond. So it needs to be individualized. But I just wanted to make the point that in contrast to asthma, this is not a lifelong treatment with omalizumab, and that it's appropriate to strive to taper the drug, again, in the context of shared decision-making. So I talked about the past in terms of the 60s and the 80s. I wanted to also talk a little bit about the future. There are emerging data regarding clinical and molecular biomarkers, some of which are shown here. These are not yet ready for prime time, but a number of them show promise. What we want to achieve is something very similar to what is shown here. This is a review article actually concerning asthma, but it's the same concept here for chronic urticaria. We would like to be able to order a laboratory test or a series of laboratory tests where we get a profile or a biomarker analysis that will allow us to determine, for instance, whether a prescription for omalizumab will be associated with a high likelihood of salutary response, or whether the patient in front of us with chronic refractory urticaria will be a non-responder and the patient should be treated with an agent other than, for instance, anti-IgE therapy or omalizumab. IgE has emerged as a biomarker that will tell us with regards to omalizumab, for instance, if somebody has an IgE level in 3 figures compared with someone else who has an IgE level that's in single digits, the one whose IgE level is in single digits is less likely to respond or to have a salutary response to omalizumab. But it doesn't mean that that individual should not receive a trial of omalizumab. The benefit on omalizumab in the individual whose IgE levels in triple figures is probably around 2 out of 3. The benefit in the individual whose IgE level is low is probably around 1 out of 3. But that's still 1 out of 3, and it's still, I would say, appropriate to offer a therapeutic trial of omalizumab despite that IgE result. So we don't have the kind of precision that we would like with a biomarker or a panel of biomarkers, but hopefully that's what will happen in the future. So this is a paper presented in the European meeting in 2019, Jonathan Bernstein, just to give you a glimpse of the potential for other biologic agents that are undergoing clinical trials and may soon be available. This is a paper in which benralizumab was studied, 12 subjects with antihistamine-resistant chronic urticaria, 9 of whom were women, mean age 47, who had a duration of chronic urticaria that spanned 7 years. This was a single-blind protocol with a placebo run-in, where they received 1 dose of a placebo and then benralizumab monthly, 3 doses, and they had 2 patient-reported outcome measures as outcomes. And you can see that following benralizumab, there was improvement in disease severity and quality of life. And benralizumab and other agents, including anti-IL-4, IL-13, more potent IgE, are undergoing clinical trials. And it's the space here is going to look like the asthma space looks in another few years, I suspect, in which we will have a selection of biologic agents. And hopefully by then, our biomarker panel data, our data regarding the diagnostic utility of biomarkers will have advanced, such that these will be able to aid us in terms of which biologic agent is appropriate for each individual patient. And there's one more thing I want to mention. The caption here reads, "Nothing serious, just a case of hives." And I want to close with the notion that although we are unable to answer the question with which patients commonly approach us, which is what's causing my urticaria, nonetheless, our capacity to help patients with chronic spontaneous or chronic inducible urticaria has improved dramatically based on enhanced understanding of the condition, our ability to implement appropriate avoidance measures and prescribe medications that are efficacious, such that patients who have come to us with this condition, who have taken on a huge hit in terms of their quality of life, even though we can't answer the question they come to us with, nonetheless, we're able to do a lot to help these patients. So I hope the next time you see a patient with hives such as this, that you're able to prescribe appropriate medication that will lead to improvement in quality of life. Thanks for your attention, and I'll be happy to respond to any questions you may have.
Okay, we'll open this up to the audience for questions.
I have a question, Dr. Lang. I'm one of the first year fellows in Little Rock, but I was just wondering, are there any scenarios that you've encountered that you felt that you had to do more laboratory evaluation when you first see a patient with chronic urticaria?
Yeah, there are times that patients are very concerned that they have an underlying condition. Generally, I think in more recent years, I've been able to persuade them successfully. But my fallback is that I do routine screening laboratory tests that I indicated, and don't do extensive laboratory testing. That's, I think, the key here. I think that the routine laboratory tests that I displayed are reasonable. It's also reasonable to not do any tests. I certainly don't do skin testing for foods and inhalants in managing these patients. You know, without a clear indication, I don't even know what that indication would be.
Thank you.
Hi, Dave.
Nice to see you, Jay.
It's great to see you. I was just at the Rock and Roll Hall of Fame 2 weeks ago when I visited Cleveland for one day. It is an amazing place.
I wish you
great
called.
talk,
I wish you
as
called me. I
always.
would have liked to have seen you. But when you come back, please let me
It
know.
was just,
No,
I'll
I
let you know
understand.
if we get back there.
Got it. Got it.
Anyway, great talk. You've kind of taken the difficulty out of treating rhinitis. Now, then asthma and eczema is easier to treat, and now even hives is not as scary as it used to be because we have effective treatments. It's really great to be an allergist right now because we have things we can do for all of these what used to be really difficult diseases. So it's an exciting time. I really love your evidence-based approach. It's really rigorous. Hopefully I'll be able to follow on with that in my presentation, which I'm giving next on diagnostic testing. But that was really great. Thank you, Dave. And I always enjoy listening to your talks.
Thank you. The feeling's mutual. Please pass along my regards to Ellen.
Right.
I will.
Well, Dr. Lang, again, thank you for participating in COLA. We hope to see you again in the near future.
Actually, there's somebody who wanted to ask me a quick question as well.
Okay, let's do that. Sorry, I didn't see it in the chat. Okay.
Okay, when we start the omalizumab and patient gets better, do you tend to wean down or decrease antihistamine doses that patient is taking, or do you usually have them continue the oral antihistamine while patient is on omalizumab? Thank you very much. Okay, so thank you for your question. Happy to answer any questions you may have. I realize the old clock on the wall here is such that I need to be brief. But yeah, you have to individualize it. I usually instruct patients to taper when they're feeling better, but frequently I will add that patients will generally do that on their own. Similarly, as patients with asthma do, when they start to benefit. I mean, some of my patients on biologic agents, they're on monotherapy with the biologic agent after a while. That's just, you know, human nature. But yeah, I think it's appropriate to look. We strive to reach the sweet spot in terms of giving people enough medication and not too much. There are patients, anecdotally, who continue to require the antihistamine, who have, you know, some minor breakthroughs. But many patients will be able to taper, and some are able to suspend.
Yeah, I've actually noticed the same thing with kids with asthma. They stop taking their inhalers.
Yep.
Kids with eczema, they stop using all the creams and lotions once their skin is cleared up. These drugs are miracle drugs.
Yeah, the one group I think who will continue taking their medications, who are on biologics, are patients I manage with aspirin exacerbated respiratory disease. They frequently need to continue to take their medications. Other than for that, it's basically what we've discussed. So I hope I answered your question, Dr. Chang. Thank you. All right, it's a pleasure to be with you, and I guess I'm signing off. Thanks.
Right. Thanks, Dr.